Thank you, sir.
Yeah,
So, shall we start, Dr. Batu?
I think we should start.
Yes.
It's almost 8:30.
Yeah. So let me start with the introduction. Yeah. Good evening, respected neurosurgeons. Welcome to MCNS 2025. This is the third webinar, and this time we'll be discussing about cerebral aneurysms, the complications and avoidance. So we'll have three presentations by eminent young speakers. They will present cases and discuss about complications like intra rupture and vasospasm. And for this, I really would like to thank the MCNS webinar committee for giving me this opportunity to moderate this session. And I welcome our esteemed speakers and panelists for their participation. So, as we all know, brain aneurysm is a beautiful and intricate procedure that teaches surgeons many lessons. So, this surgery indeed presents complex challenges to us. It tests neurosurgeons' expertise and humility in the face of unpredictable intraoperative and post-op complications. So, this procedure demands highest precision, patience, skill, and that can be honed through experience and dedications. So today's MCNS webinar and our esteemed speakers and panelists will help us to understand and enhance our knowledge in avoiding and handling the most deadliest complications of aneurysm surgery. So our speakers will discuss the critical topics. The first will be by Dr. Kamlesh Baisura. He is a professor in SD Vijay Medical College, Lucknow, and he will discuss about the intra rupture, how to avoid, and what are the steps to be taken. So the next speaker is Dr. Chaitanya Godbole. He is from Satara. He's a dual trained neurosurgeon, hybrid neurosurgeon. He does intervention as well. He clips aneurysms. He will be discussing about the management of vasospasm medically and even how to take the help of intervention if needed. And last speaker will be my colleague, Dr. Avishkar Khada, who is presently shifted to Pune.
Good evening.
He will discuss about one rare complications that we had in 600 aneurysms we clipped, that is a DACA aneurysm. There was an intra vasospasm. So we want to learn from the speakers and even from the panelists and the participants that what could have avoided and what can be done. So these will be the three presentations, and we have three eminent names in Indian vascular neurosurgery. Mainly Professor B.K. Mishra sir, who doesn't need much of introduction. He's a well-known, renowned vascular neurosurgeon in India. And second is Professor Batuk Deora, who also is a dual-trained vascular neurosurgeon practicing in Mumbai. And both these, B.K. Mishra sir as a chairman and Dr. Batuk as a secretary, they will be hosting 25th Neurovascular Conference this year in Mumbai. So the third panelist is Dr. Nitin Dange, who also is a very senior neurosurgeon and an endovascular specialist who practices in Mumbai. So we have our Dr. Chaudhary sir, Kishore Chaudhary sir from Sheffield, UK, who is a senior most vascular neurosurgeon and who is a co-moderator with me, and he is also the chairperson for the webinar committee. So without wasting much of time, we'll start with the presentation. First will be Dr. Kamlesh. I request all the three presenters to kindly stick to the time so that we can have a beautiful discussion and can learn from all the panelists and participants about this cerebral aneurysm complications and how to avoid them. So over to you, Dr. Kamlesh.
Thank you, Shiv Shankar. We'll definitely try that.
Thank you.
Stick to the time which was allotted to us. First, I will thank MCNS and Dr. Shiv Shankar for giving me this opportunity to present on this August forum. And my topic is intra aneurysm rupture, steps to avoid and mitigate. This is a complex topic. I think I will do some justice to this topic. So, sorry. Okay. So intra rupture of aneurysm can take fun out of the surgery. You know, we are doing complex microneurosurgeries at different time. But whenever this intra rupture occurs, so there will be a situation of panic and some fun is taken from that surgery. This is a simple proximal A1 aneurysm. I have dissected this aneurysm and I was showing my resident during ICG, the aneurysm and aneurysm rupture. So this was captured during doing an ICG. We were totally unprepared and for this complication. So panic situation created. So we somehow managed this situation and patient went well home. But this situation can arise at any time during surgery or during aneurysm surgery. So we have to be prepared and trained for this kind of situation for in the aneurysm surgery. So this sentence which comes in my mind, we don't rise to level of our expectations. We fall to the level of training. So on a given day, we can be doing a great surgery and vascular surgery, but our test of training occurs when this type of complication occur, how we manage it. So training matters of vascular surgery, especially managing these panic situations. So intra aneurysm rupture account for 0.3 to 50% of cases reported in literature. How you define that intraoperative rupture, minor, major. So the reported cases may be up to 50%. They have included some in literature in minor cases. One in recent literature, it has come down from 3 to 12% of cases of they have reported cases in behavioral literature intraoperative rupture rates. And this misadventure can contribute to poor outcome. When a beautiful surgery can be ruined by this if you are not trained to properly manage this kind of complication. And in the era of hybrid neurosurgery and endovascular surgery, as we are getting lesser aneurysm, simple aneurysm clipping, the microneurosurgeons are now facing more complex aneurysm, and complexity may increase chance of intraop rupture. And we should be trained for all these to manage this intraop complication. So intraop aneurysm rupture can be occur in 3 phases. During surgery, pre-dissection phase, where we are totally unprepared. We have not dissected, seen aneurysm, dissection phase, and clipping phase. Whenever this complication occur pre-dissection phase, we are totally underprepared. The outcome is worse than other phases. Like the better in clipping phase, we have already exposed aneurysm. We can manage the complication in due course of time, and the outcome may be better. But in pre-dissection phase, whenever aneurysm ruptures, we can expect the outcome will be poorer. So in pre-dissection phase, what can lead to aneurysm rupture? It may be a hemodynamic changes during induction, pain fixation, surgical incision. So proper hemodynamic management of these patients is very paramount. So we should keep all these things in our before starting surgery. A rapid bolus of mannitol, excessive hyperventilation is reported in the literature to cause pre-op or pre-dissection aneurysm ruptures. And excessive release of CSF, especially in aneurysm, which is embedded in the brain, maybe have been reported in the literature to cause early rupture of aneurysm. We all know due to the brain shift, as we release CSF, brain fundus is whenever embedded brain, the brain shift can lead to traction of fundus and may lead to aneurysm rupture. So I am similar case I am showing you. This is a 30-year-old female patient who admitted to grade 3 SCH. We can see a basilar top aneurysm, which is embedded in the brainstem. We can see, and brainstem edema we can see. And this large aneurysm, recent progressive explained to patient. He was offered surgery. He chose surgery due to various reasons, financial, and there was no one, somebody was getting her treated. So they agreed for surgery due to financial reason. And so for this patient, we plan to do Dolenk and Kawase approach for exposure of aneurysm and transcavernous clipping of this clipping. And we have done frontotemporal craniotomy. We can see zygomal lowering. We have peeled the cavernous sinus dura. We have prepared the cavernous rhomboid for drilling. Extradural craniotomy already done. You can see. So we decided to take this. We can see the cover, release some CSF before opening a dura and take rest before next stage of surgery. So it was a simple T break where aneurysm ruptured. We can see brain bulged. It was both frontal temporal lobe was bulging. So whole team have to join. In my seniors, Dr. Arun and Dr. Kuntal, we are whole three of involved during managing this patient, which was tends to be a beautiful surgery. Now we have done temporal lobectomy, frontal lobectomy, cutting of tent, And the exposure was also new because we are now able to drill the Kawase triangle to take vertebral artery distal basilar control. So whatever control we are getting, we are managing that. We can see third nerve, temporary were applied whenever we got the proximal control on basilar artery. We are dissecting the neck and the aneurysm was clipped somehow, but we can see brainstem. So aneurysm would embed in the brainstem were pushing upward due to hematoma. We clip the aneurysm and decompress the aneurysm, remove fundus, thrombus. The patient post-op post-ostomy, we could able to the patient discharge gradually on post-op day 20 with spontaneous eye opening and M5 response. She's still recovering. We are expecting her first post-op visit after 6 weeks. And second stage, dissection phase, where we can have aneurysm rupture. Causes may be various, like retraction application, wrongly applied retraction, separation of vessel and perforator for aneurysm, hematoma removal, and one special subset are blister aneurysm, which has high rupture rate up to 40 to 60%, and sometimes difficult anatomy. So can lead to we can get surprise during surgery and disease vessel wall, especially atherosclerotic vessel vehicle old age patients. And these all factors can lead to aneurysm ruptures during dissection of these aneurysms. So similar case, I will show this phase, a 20-year-old male patient is a giant MC aneurysm. We can see silver fissure bleed. The aneurysm was taking one branch of MCA. So our plan was to make STMC bypass for this patient. If we are not able to reconstruct the neck, we take an STA. The surgery was going well. Then we were dissecting the silver fissure after taking STA. We have prepared for STMC bypass. And we can see hematoma, silver fissure open, hematoma removed, brain got lax. We are dissecting both M2 branches and M3 branches up to the aneurysm. We kept some layer of hematoma on the fundus. But the aneurysm is so giant, we are not able to get the proximal M1 from this side. So this is both M2 we are dissecting. So the going distal, I first have to control on ICA for proximal control if something happens, because the aneurysm or resting of M1 branch. During this, suction was cause of bleeding aneurysm. We can apply it last temporarily for aneurysm rupture site. We can control the rupture site, all these five already. Then M1 was taken under control, and you can see aneurysm got lax after applying temporarily for M1. So then we realize that, and after doing all these procedures, the aneurysm, we can reconstruct the aneurysm. Yeah, after aneurysm locks, we can see that I am trying to reconstruct the aneurysm neck with multiple stacking clip. So rupture forced us to do this step, but ultimately it's going to be a blessing in disguise. We need not to do MCTSD bypass, and I reconstructed the aneurysm nerve with multiple stacking clips. Temporarily removed, and you can see ICG aneurysm was exploded for circulation. Both M2 was filling nicely. So the rupture of aneurysm has led to change of plan in this case. So another case, this is ACOM aneurysm. We can see arising from ACOM artery. This is a true ACOM aneurysm. Both ACOM, ACA are codominant. And this in this stage, we can see we have dissected aneurysm beautifully. We can see both A2s, ipsilateral A1. I am dissecting contralateral A2 from aneurysm. Proximal neck, I can, or ipsilateral side, I can define neck with sharp and blunt dissection, but I am not able to separate contralateral A2 from aneurysm fundus. So I applied temporary so that aneurysm can become lax, and I'm able so that I can able to dissect the contralateral A2 from aneurysm fundus, but it is not. It's a densely adherent. So one thing I forgot to put temporarily from contralateral A1. I forgot that circulation codominant, And dissection going on, I'm creating more and more rupture or rent on aneurysm. So sometime in these kind of situation, simple steps can be forgotten, and this can lead to prolonged surgery or some. Yeah, I'm trying to clip, not able to clip. I have increased the rent in the aneurysm. So then after that, I have applied temporary on contralateral A1 also. So bleeding stopped. Now I can see aneurysm more clearly. Good. And dissected the aneurysm with fundus and clipped with simple one curve clip. So proximal and distal control, you know, complete trapping of, you know, we can say trapping of rupture site is necessary because for absolute hemostasis, so that we can take do good clipping of this kind of a patient. Because if we continuously bleeding, it will be difficult. Surgeons will be in panic and surgery results may not be same. And sometimes difficult anatomy can lead to this kind of lecture. We can see a typical ACOM aneurysm we have defined arising from junction of A1 on ACOM junction from we can see this was a patient presented with grade 1 SAH. But during surgery, we have to control on dominant A1 and ICG, we are able to see the aneurysm arising from junction from A1 ACOM. But when I dissected the aneurysm, we can see the ACOM is fenestrated. Yeah, one fundus is resting on another ACOM, and we have very little space to dissect the neck of aneurysm. I'm trying to dissect it, so I have to manipulate fundus of aneurysm, and this will lead to some ruptures at fundus side. Fortunately, this is dominant A1, and so sometimes these difficult anatomy can give surprise you during surgery. In pre-op CT&G, we are not able to identify this fenestrated ACOM. After dissection, we clip the straight clip. Because small neck is remnant neck can be seen below this neck, and reinforcing clip was applied. Patient did well post-operatively. So difficult anatomy sometimes can make your job difficult, but whenever knowledge you can get in pre-op radiology, we should always look for these type of different anatomy, and we should anticipate pre-operatively. Another complication during dissection, you can application retraction. If you are not we have dissected this aneurysm, dominant A1. I am opening the antehemispheric fissure. Ipsilateral A2 is under my control, and this is opening of aneurysm is directly anteriorly, and it is resting on ACOM, maybe densely there. Yeah, this application of retraction cause tear in the fundus because it was adherent on chiasm. So in this case, assistance is very necessary. You need a good assistance who can put another suction inside. Temporary clip applied. We have identified rupture side and keep a small cotton on this and with wide bore suction so that field can be clear. We should not peg indiscriminately. It can lead to bag in the CS system, which will lead to the brain bulge. So focus cotton and suction is applied, and now under this field we can dissect the aneurysm, because whenever field we have anti-dactyl aneurysm, we are confident that we will see aneurysm neck. So the straight clip was applied along the ACOM, and this aneurysm was clipped. We can see contralateral A2. We are confirming it is not in clip, and contralateral A1. The aneurysm was clipped nicely. So this was a suction. Your assistant and matters most how he can clear the field. Simple plugging of cotton and suction can lead to clearing of field and proceeding of surgery. The third phase is clipping phase. Rupture during clipping may be due to inadequate exposure, wrong clip selection, size, shape, and type. So what clip I am going to apply should be decided pre-operatively, whether this clip available in my clip box or not. A better drawing is may help in better clip. Clip application of tense aneurysm is another cause of rupture during the clipping and diseased vessel wall. It can clipping during these vessels can tear, especially, and these animal rupture from necks and can lead to disaster complication.
Dr.
Sorry,
Kamlesh.
we spoke at the same time.
Yeah.
Time is up.
Time is
I will-
15 minutes
I will-
over.
I will conclude, sir.
Yeah.
So this is a clipping aneurysm. I want to show due to lack of time, I am not able to see. So I would like to see this reviewed article where they have done structure size of aneurysm and clot and fundus have found to we have more rupture rate during surgery. So and this they have shown the odd ratio of increase of odd ratio of worst complication has increased during the inexperienced surgeon and major intra rupture. So what I have learned all these years during this managing how to manage these patients, the planning of proximal and distal control, elective application temporarily before permanent clip, net dissection first, leave a cup of brain and hematoma on fundus, and pre-op planning of permanent clip may reduce the rupture rate of these aneurysm intraoperatively. Thank you.
Yeah, thank you, Dr. Kamlesh, for that wonderful presentation and sincerely showing all those complications and how you handled. Aneurysm rupture is ever present and it is the most feared complication in neurosurgery. So we had a good opportunity to learn from you. Because of time constraint, we'll take the questions at the end. So now may I request Dr. Chaitanya Godbole from Satara to talk about vasospasm. He is a neurosurgeon, duly trained. He does intervention and even clipping also. So he'll present about post-op vasospasm by medical and endoscopic options. Over to you, Dr. Chaitanya.
Thank you, sir. Are my slides visible, sir?
Yeah, it's the scene.
Yeah. So I thank MCNS webinar committee for this opportunity and also for good webinars over the last few years, which are very helpful to plan some surgeries before actually going for it. Today's topic being cerebral aneurysms, I'll be discussing about post-op vasospasm management, myself, Chaitanya Godbole. So vasospasm is very common and almost 10% in spite of best treatment will have morbidity and mortality because of vasospasm. In pathophysiology, there are basically three types. So this is important to understand because our treatment will depend on this pathophysiology. First type of vasospasm is mild form of vasospasm, which is usually because of heme breakdown products causing calcium entry into the smooth muscles and vasospasm. This is reversible. This is reversible with Triple H, with our intraarterial nimodipine and all. And this is a milder form. The second phase, that is chronic phase, is more permanent change with all interleukins and everything coming into picture, causing permanent structural damage or changes into the protein, contractile protein structure, as well as vessel wall. This is difficult to improve with medicines and may require ballooning, etc. These are the common risk factors for vasospasm, which we all know. I will not go into details. So sometimes there is vasospasm in completely different territory. I clipped one ACOM aneurysm. There was no blood in posterior fossa. And on third day, patient deteriorated, did MRI. It showed cortical peripheral infarcts in cerebellum, in ICA and PICA territory. There was no blood there. It had nothing to do with that. So is this normal routine pathophysiology of vasospasm, is it explanatory to all conditions? I guess no. Why there is vasospasm into some smaller branch, sometimes into M3, M4 branches, while sometimes it is vasospasm more into M1 branches? We are not sure, in spite blood territory being same. Are there any other pathologies like cortical spreading ischemia or microemboli or secondary hit like we see in trauma after aneurysm ruptures. Are these pathologies, do they play a role? Probably yes. They have been found to play a role in animal studies and very few human studies. They cause some apoptotic changes into the blood vessels. So there are these three pathophysiology of delayed deterioration, and our treatment depends on this pathophysiology. So we rule out other causes of delayed deterioration like hematoma, contusions, or edema, increase in edema, hyponatremia, hypox. This we all routinely do. We rule out other causes of deterioration. If there are no other causes, then we move to diagnosis of vasospasm. You can do transcranial Doppler, which is more favorable in MCA. But for other territories, it is slightly difficult. Other imaging which we usually do is either CT or MR-angio. And if not, then direct catheter-based angiography for the diagnosis of vasospasm. The routine measures which we take to prevent the vasospasm are common, that is euvolemia, maintain hemoglobin up to 9, and prevent other complications like desaturation and etc. I would like to stress upon this nimodipine tablet 60 milligram 4 hourly or 30 milligram 2 hourly depending on BP. This has shown to cause statistically significant improvement, though very modest, but it is there. Not just because it is calcium channel blocker, I guess amlodipine doesn't work. So there are some other uses like neuroprotective properties or clot-lysing properties of nimodipine, so which help in prevention of vasospasm. Now, if we have a vasospasm which is confirmed, like we do all this testing, there is no other cause like no edema, no infarct, no hematoma, then we confirm the vasospasm, and then how we treat. First we do is triple H, that is increase the BP, increase the CVP, hemodilution a bit will automatically occur, not necessary to chase it. See, reassess in 1 hour. If patient improves, then we continue the triple H. If not, then we try to be aggressive on the triple H, that is increase the CVP more, increase the BP more, and reassess. If there is improvement, then we keep treating the patient, post-operative vasospasm patient with triple H if there is improvement. If not, then ideally we should go to DSA, I mean the cath lab. And if there is no cerebral edema and the spasm is slightly peripheral, then we can consider intraarterial injection of drugs. If not, there is, because these drugs will cause increase in intracranial pressure. So if there is already intracranial pressure and you give these drugs, there may be deterioration. So knowing rough estimate of intracranial pressure is important to decide whether to go for drugs or do balloon plasty. Sometimes this is many a times this is not that straightforward. Patient is having vasospasm, patient is having edema, patient is having hematoma. There may be multiple factors, and then we have to tailor-made our approach. The issue with triple H is this cardiac and pulmonary. So sometimes it is not, especially elderly people with frail reserve. This may not be possible always. So triple H therapy has shown to reverse the neurologic deficit. Whether it affects long-term outcome, like at 6 months, we are not very sure. Second thing which we have is either give vasodilator infusions. That is, it is just like DSA. Just go into internal carotid, instead of injecting contrast, inject vasodilator drugs like nimodipine, verapamil, milrinone, and all. Its action is delayed. It is short acting and may require retreatment. In 15 to 20% of the patients, this may require retreatment, and it causes elevation in intracranial pressure. It is more effective in distal vessels, but I'll show you examples where M1 and IC also do open up. If this fails, or if the patient is in third chronic phase, that is with permanent change in the vessel wall, then we have no other option but to do balloon angioplasty. It gives immediate results. It is durable, but there are complications like perforation, dissection, thromboembolism, you name it. So, personally, I am a bit more towards vasodilators than actually doing balloon testing, balloon dilatation. There are multiple factors, cost and but balloon is good. The improvement is average 50% post ballooning, and retreatment rate is just 3 to 4%, though the complication rate is about 10%. So this webinar, will be available on YouTube. We can just take screenshots, and I have mentioned all the drugs and their dosages, how to give it. Verapamil is preferred by many. Previously we used to use papaverine, but like this is the oldest, but it causes a lot of issues like raised ICP and respiratory issues. So papaverine installation has been stopped. Milrinone is another good drug, and others like NTG we can use. So this is an example of this is an example of installation of verapamil. This is M1 stenosis, M1 vasospasm. Verapamil infusion after 15 minutes shoots, you see it is almost same, not much of a difference. But if you wait for 1 hour, there will be all the M1 looks good, like as if we have done balloon plastic. So don't get disheartened by injecting these drugs that there is no opening. So either wait for 1 hour, which is not always possible in cath lab. There are cardiologists waiting and all waiting. So have a faith, it does open up and there will be clinical improvement. So the last option is balloons. There are multiple types of balloons, compliant balloons and non-compliant balloons. Non-compliant balloons are mainly cardiac balloons, which are over the wire single lumen balloons. By compliance, I mean they are stiff. That is, if they open up, they will push the artery more compared to these compliant balloons. We have neuro balloons, which are double lumen, where you can take a wire into the lumen, also inject some drugs through this lumen. At the same time, you can do balloon plasty at the proximal part. This is dangerous, so we have to be very slow, 20% increment each time. This is our vasospasm. Vasospastic vessels are compliant. They are not atherosclerotic. So we have to be careful. Keep on slowly ballooning, gradually go in, and don't achieve 100%. Stop at 80%. The issue of compliant versus non-compliant is here. If we balloon like this in this vessel, complete ballooning, then non-compliant balloons will cause more force at this vasospastic area. And if we are over ballooning, there will be rupture from vasospastic area if we are using non-compliant balloons. If you are using compliant balloons, then those balloons will tend to inflate more distally and proximal. So there will be rupture either distal or proximal. So this is one example. This is how the balloon will look. There are markers of the balloon we can place along the area where we want to balloon it. And then after ballooning, there will be opening of the vessel. This is another example where MCA is spastic. After ballooning, there is good opening. We have to be careful about the visibility. As you can see here, there are two vessels overlapping. If you by mistake balloon in another vessel, there will be rupture. So be cautious of anatomy. Another MCA ballooning. This is interesting. So this is spasm of ICA, MCA. You balloon it, there will be improvement in the size. But you see, ACA is also very spastic. There is almost no flow. You can't balloon this. So, and if you inject any drug, verapamil or whatever, it will tend to go into MCA because of good flow there. It will not go into ACA. So what we can do is balloon and occlude the MCA transiently and give the drug so that it will preferentially go to the ACA. And as you can see here, whether you can see or not, yeah, so ACAs will feel better. So this is the combination which we can do. This is the post-clipping spasm of basilar and post-opening. I'll just share this complication. If you take long balloon, when the spastic area is small, this is a this balloon will expand proximally and distally. And if you are over expanding, then there will be rupture, as you can see here, distally across the distal M2. So this is all this contrast going down is the leak, that is rupture. So my take-home message would be there are two pathologies of vasospasm, simple muscle contraction, and second is change in the artery, actual artery. So for mild to moderate, you can use triple H or transcatheter drugs. For severe, you may have no other option but to use balloon, or you can use combination. Sometimes it may not be just vasospasm. There may be some patients are very aggressive, some deteriorate very aggressively, some behave very nastily. So there may be some other pathologies like I said before, cortical spreading ischemia or depolarization or second hit after rupture and raised ICP. So these things may also be there. Maybe we are not very sure about that, but in our clinical practice, we do find cases which are not explained by routine things. So thank you for that. I think I'll stop.
Yeah, thank you, Chaitanya. I think you finished in the right time. So we'll have a good amount of discussion at the end. So
Yes.
as we all know, the cerebral microvascular anatomy is severely altered by the hemorrhage into the subaqueous space. And this is the most deadly complications, and most of the patients and morbidity mortality happens because of vasospasm. And Dr. Chaitanya has shared very well about the medical management and even the beautiful pictures and videos about endoscopic management of these cases. So thank you, Chaitanya, for that wonderful presentation. We'll move ahead to the last presentation by Dr. Avishkar, who is my colleague and presently practicing in Pune, neurosurgeon practicing in Pune. He'll talk about a case of Dhaka aneurysm, where we had an intra severe spasm, and we did all what was possible at our place. So, Dr. Avishkar.
Yeah.
Yeah, you can
Good
see
evening. Good evening, everyone, esteemed panelists and respected moderators, seniors and friends. At the outset, I would like to thank MCNS webinar committee to give me a chance. Are you able to see my screen?
the presentation. Yeah, yes. You're seeing.
Okay. So this was a case of a Dhaka aneurysm, which we did when I was at Siddhagiri with Marjakke sir. And this lady of 60 years, she presented to us on day 1 of her rupture with history of sudden onset severe headache and altered sensorium. She came with a GCS of E4M6B5, that was grade 1. And we did a CT angio which showed a diffuse subarachnoid hemorrhage with a large saccular aneurysm arising from the A3 segment of right ACA. Relatives were counseled regarding the need for intervention. Options of both microsurgical clipping and endovascular interventions were given. But somehow they left citing economic concerns. And surprisingly, they were back on the 4th day after the ictus with a slight deterioration in her GCS. She was E3M6V4 at that time. Her WFNS grade was grade 2. They chose for microsurgical clipping over the endovascular intervention, and she was then taken up for surgery immediately. Yeah, before going to the surgical video, I would like to share this clip, this image where we can compare the radiological anatomy with the intraoperative anatomy. We can see the aneurysm arising in the sagittal scan, arising from the A3 segment. And in the coronal view, we can appreciate the difference in the caliber in the vessels on left side and the right side. In the intra picture, you can see that the aneurysm is draped by the right-sided A3, which is the callosum marginal artery, and the fundus of the aneurysm is seen on both sides. The left A3 is also seen draping the lateralmost part of the aneurysm, and the pericallosal artery is ventral to the aneurysm. So you can imagine the aneurysm is a horizontally oriented aneurysm with a dumbbell shape caused by sandwiching between the dorsal callosum marginal artery and the ventral pericallosal artery. So now I would like to go to the surgical video. Are you able to see the video?
Yeah, it's seen.
Yeah. So as discussed, CT angio showed a right A3 aneurysm. We can appreciate in all the three views and the difference in the caliber. In this 3D reconstruction, we can plan our surgical approach and get a good orientation about the relation of the branches with the aneurysm neck. So we went ahead with the standard interhemispheric approach, bifrontal craniotomy, dural opening on the right side. You can see these cortical draining veins. We saved it. We had a very small, approximately 1 centimeter corridor through which we approached the aneurysm. Now this is the intra picture. You can clearly see the blood vessels wrapped. This is the callosum marginal. This is a small frontal branch which is arising. Here, the right callosum marginal, the left A3, this aneurysm on the left side and aneurysm on the right side also. So this is a dumbbell shaped horizontally oriented large saccular aneurysm, and the pericallosal artery is seen ventrally to the fundus. So we started with the dissection. You can see the pericallosal artery here. This one, very clearly the teat. So dissecting the aneurysm. Before dissecting, we applied the temporary clip over the A2 and started dissecting. Sharp dissection was used. Dissection from the pericallosal artery. Dissection from the left A3 segment. We usually use an insulin syringe to dissect. We have to make sure that we should not injure the adventitia of the vessel which we are dissecting. Very meticulously and slowly we have to do it. So once the aneurysm fundus was dissected free, this is the right callosum marginal artery, which is so densely adherent to the fundus that we didn't try to separate it. Otherwise, it would have led to a rupture. So we use this technique to shrink the fundus by coagulating the fundus using the smallest possible power of the bipolar cautery so that we can reconstruct the neck properly. You can see the teat here where it had ruptured. So first, after this, we did a pre-clipping ICG angio. Here you can clearly see this is the left A3. This is the callosum marginal, which is draped over the fundus of the aneurysm. And you can see the left pericallosal, which lies ventrally to the aneurysm, this one. And this is the proximal A2 vessel. So again, We chose a 7 mm straight fenestrated clip with the callosomarginal artery passing through the fenestration. We made sure that the distal clip blades did not occlude the ventrally lying pericallosal artery. We inspected. We removed the temporary clip. Again, inspecting for the adequacy of the clipping and freedom of the distal branches. Then we used a Doppler. A Doppler showed a flow in the pericallosal artery, but a weak flow in the callosomarginal artery. And then we did a ICG also. ICG also confirmed that there was correct flow in the pericallosal artery, but the callosomarginal, which was draping the aneurysm dorsally, didn't show a good flow as compared to the vessel on the opposite side. You can compare this. So we thought that we will readjust the clip. Fundus is clearly not showing any flow. So we further, after applying the temporary clip, we further tried to shrink the fundus. And then reapplied this fenestrated clip. And again did remove the temporary clip, again did Doppler. This time reverse happened. The callosomarginal artery was showing the flow, but the ventrally lying pericallosal artery, there was no flow or very low flow on the Dopplers. So we were getting anxious by this time. What is happening? And you can see, you can appreciate the caliber of these vessels as compared to the pre-clipping and pre-dissection period. These have become more smaller and they appear to be vasospastic. We again reconfirmed our clipping, whether it is catching hold of any of the branches. That's why whether we are not getting the flow, but it was not so. We thought we will make sure whether the blood vessels refill by applying a more proximal clip. We removed the more distal clip. We removed the proximal clip. You can see the fundus is pulsating, but the blood vessels still didn't show proper flow on Doppler. It was very low. Clearly, they were in spasm. So we flooded the field with papaverine, waited for few moments and again did the Doppler, but it was not showing the flow. All the vessels, all the right-sided branches were in spasm. So we again reapplied the proximal clip, removed the distal clip. Again tried the same things, but same, the blood vessels were clearly in spasm. So we removed, again reapplied. Even the fundus, you can see it has collapsed and is not filling as it was filling earlier. So we again applied the temporary clip, and this time we thought we should rule out whether there is any thrombus formation inside the fundus or the proximal vessel. So we, after applying the temporary clip, we opened this thing, but there was no flow. We partially clipped the aneurysm and then removed the temporary clip. The open fundus was not showing any flow, and the Doppler also was not showing any flow in the distal vessels. We even used Kivo tool to examine the adequacy and patency of the vessels. We tried nimodipine, injecting nimodipine intra-arterially directly through the opening which we had made in the fundus, but it also didn't help. And we were desperate. Our neuroanesthesia team was also trying all the measures to reverse the vasospasm, cerebroprotective interventions. As a desperate last measure, we tried dilating the path by inserting this Roton's dissector. And after that, flow came through the fundus. So we final clipping, we occluded the opening by and the neck by angle clip and a fenestrated clip. But even after this, though the fundus had shown the flow, the distal vessels were not showing flow on Doppler. So lastly, we again injected papaverine, waited, did a final ICG, which was not showing any flow in the distal vessels. The aneurysm was not seen. The proximal, both A2s were seen clearly, but distal vessels were not showing flow. We got an immediate post-op MRI, which showed acute infarcts, acute patchy infarcts in the right A3 territory. CT angio next day showed that the aneurysm was obliterated completely, but the distal vessels, distal to the clipping, right-sided A3 and A4 vessels were not showing any flow. And patient actually, when she was extubated and she woke up with a right-sided hemiplegia. We were not expecting hemiplegia even with A3 or A4, this thing, ischemia. Even her left lower limb was 0/5. So this clearly means that she was in vasospasm. And MRI didn't show any infarcts in the MCA territory. Here also in 3D reconstruction, you can appreciate that the right-sided vessels are not seen. This is the right A2. These are the left-sided vessels which are seen. So here, so as I mentioned, in the post-op period, she woke up with a hemiplegia, which recovered over period. And at 3 weeks follow-up, she had regained complete power in her lower limb, in the upper limb, but the lower limb had also improved, but it was 2/5. So in spite of all the measures to reverse the vasospasm, like local papaverine, raising the blood pressure, IV, and even intra-arterial nimodipine, we were not able to reverse the vasospasm. Only remaining thing was that we didn't have an emergency availability of endovascular intervention at hand. And even the patient party was not affording to that. We here sincerely are sharing this complication, which we have experienced, and hope for a positive discussion from this case and to learn from seniors who can guide us more as to how we can get through such situations. Thank you.
Yeah, thank you, Dr. Avishkar. Kishore Chaudhary, sir, can you take on? Hello.
Thank you very much for all the three lovely presentations. And I was very impressed by all three presentations. Very succinct, very clear. The videos are very clear. So Dr. Basan Misra is also here. So without wasting time, I think let's start from the panelist. Any comments? Dr. Misra, can I invite you? And then we'll pass on to Batuk and yeah.
Yeah, thank you. Thank you, Sipsankar. Thank you very much for inviting me in this webinar. Very interesting discussion. Thank you, Kishore. I'm not seeing any other people, so I can't say who are all there. But anyway, so I just have a couple of comments. One is the first talk, very nice demonstration of the how to manage intra-op rupture. The only thing which I missed was, I don't know whether I missed it or he didn't talk about it, is adenosine. You don't use adenosine, Kamlesh?
Sir, I have not used till now adenosine. I have no experience with adenosine, sir.
Why? This is a very simple thing to use. I mean,
Message
So
stable.
I am as if for last 10 years, I have not witnessed using it also. We are not using adenosine. For last 10 years, I have not seen anybody using adenosine HGP. Yes,
Yeah, that I'm surprised. Adenosine is a very simple drug which can be used with very little morbidity. And I mean, we've been using for last maybe 15 years now. So I don't know why I'm surprised that you didn't use it. Because some of your problems you can get away with, you get 20, 30 seconds or maybe 15 seconds. I mean, we have used large, giant aneurysm, major problems. We have used 10 times, 8 times, 9 times. Very unlikely to have problem, except that the patient has a heart block. You can't use it, and you should have a defibrillator. Usually we have the anesthetists have this disposable defibrillator in our theater, but we have never had an occasion to use it. So that's one of the precautions you need to take, that you have a defibrillator, because sometimes there is theoretical possibility that patient would not to kind of heart will not revive, so you need to defib. So that is one comment for. So I think try next to it. Call your anesthetist dog. It's a very simple thing. I mean, it's not a very difficult drug to use.
but
So
till now we are able to manage without adenosine. The
yeah,
adenosine.
but you will manage better, na? Adenosine. Try that one. Talk to your anesthetist. Okay, so that one, and the next presentation about vasospasm, that was a very big subject. There's a very kind of you can have full 1 hour. Still, you will not complete. But he summarized very well. The only thing which have changed, and many of us have stopped doing, is Triple H. We don't use Triple H anymore. The standard of care has moved away from Triple H to Double H or only H. Hypertensive rather than
Hypertension only.
only hypertension. We don't use. In fact, there is now there are guidelines. There is double NS and stroke. They have guidelines. Triple H is gone out of favor.
Yeah.
Even the hemodilution also is gone out of favor. But though I use hemodilution, but I don't use the hypervolemia, because there is enough data available now. It produces more complications than otherwise, especially in this category of patients who are elderly, multiple comorbidities, cardiac issues, and so on. So that's one comment for the second talk. And the third talk was a very confusing case. I still can't understand what happened. Just one comment for the presenter. I think it would have been better if you would have seen the plain CT first. See how much blood is there. The Fisher grade blood is very critical, to see that. The only other thing I can think of is to get so much of spasm intra-op. I mean, I have never seen something like this, but what I've seen is I did see you have a temporary clip for reasonable period of time. Now, if the patient, he's on the C, I think, probably fourth day, and she had gone home, like you said, she might have been dehydrated. It's possible that one thing which had happened with me, once at least happened with me, is a clot. While you put a temporary clip, a prolonged temporary clip, there is a clot inside the main vessel, right? So I have shown in kind of many patients, many meetings. I have shown that we have opened up the vessel and kind of bled back, and that takes care of everything. To get into spasm so much without a occlusion of the vessel, and there is no bleeding, you opened up the aneurysm, there was no bleeding. There has to be occlusion of the there is. So that is the only thing I can think of that which might have happened, which might have been might have caused the problem which you had, because so much of spasm intra patient with coming with a normal vessel, I mean almost near normal vessel when you operate it, is very difficult to kind of understand what happened. I don't know whether it is there, but this has happened to me once. So I have opened it was happened. It was a ICA giant aneurysm, which was kind of aneurysm raphe. I had a temporary clip, temporary occlusion in the neck, and I clipped the aneurysm. And then when I did the ICG, I could see that it's not feeling well. So I opened up the ICA, back bled it, and then put a pursing suture. So that took care of it.
Yes, sir. In
Thank
this
you.
case, it was actually
And
done by us. This patient, the A2 and A3 up to the neck of the aneurysm, it was filling, sir. There was no thrombus in that. So distal to the neck, both the callous-marginal and the ventral pericallosal artery, they are not filling. So only thing that we did new in this is that we correlate the fundus very rarely, that mainly in the MCA bifurcation aneurysm. This is a first time we use the coagulation or the DACA aneurysm at this moment, because it was quite oblong, horizontally oriented aneurysm. It was rather along the flow of the vessel, it was oblong. So
I think as you go more
Last, may I
peripherally
ask?
to M3 and A3s, the force of temporary clip may become too much for the very small vessels, and then they become more susceptible to spasm, especially if you keep them for a long time.
no, it was
So we kept it for 4 minutes, 3 minutes. Thrice we had clipped
Okay.
temporary clip. 4 minutes, 3 minutes, 3 minutes. That's what I remember.
The other
And
thing is dissection. I mean, without a block, it's extremely unlikely that the vessel will not bleed. The artery is blocked. I mean, the proximal artery somewhere is blocked.
so,
it
but
was-
the last ICG which we did, it showed both the proximal A2s very brightly. That's what was very confusing to us.
it opened up when we dissected using a roton dissection.
I know, I saw that.
Yes,
I saw
yes.
that. Maybe you dislodged the clot and then you again you got it. I'm just this is a hypothesis I'm thinking of. I can't because I cannot think of by the way, the coagulation is never, I mean, I always coagulate. Every single patient aneurysm I coagulate to reduce. I mean, especially a large aneurysm, I coagulate. And this is something which you have learned from Professor Asagil. I mean, he coagulates, opens up the vessel. So I don't think coagulation on the fundus would cause a problem with your vessels going into problem. No, I don't think so.
Perhaps we should take comments from Batuk and then Nitin as well. So, Batuk,
Yeah,
you want to come in?
yeah. Thank you, Shiv Shankar and Dr. Chaudhary for the allowing me to moderate the session. All the three presentations were excellent. Kamlesh has nicely shown how the aneurysm has ruptured in his cases and how he is managed. I'm very much curious to know about why, in the first case of basilar artery aneurysm after dissection, and what happened during the tea break time, and suddenly there was a simple, not simple, I would say. Suddenly, the emergency came and multiple neurosurgeon has to take over the things like. Kamlesh has also nicely talked about the chances of aneurysm rupture during the pre-dissection, dissection, and the clipping phase. We all know about if the aneurysm rupture during the pre-dissection and dissection phase, it's more morbid in compared to the clipping phase. Also, the rupture depends upon the location of the aneurysm. We have to be very careful about this, and we have to plan in such a way like. So, IC aneurysms are comparatively more prone for rupture, along with then subsequently the AFib aneurysm and the MCM and DACA aneurysm rather than the MC aneurysm. And the posterior circulation aneurysm are relatively least about the among the rupture during the surgical procedure. Kamlesh has also mentioned about the blister aneurysm. Blister aneurysms are very notorious if you are trying for a surgery, because still and many endovascular guys say it's endovascular is better, and the surgical we know about the surgical problem. So one has to be very cautious while dealing, and always, because these aneurysms mostly we see in the ICA, supraclavian ICA. So proximal control in the neck is, I think, it's must in these cases. Uh, uh, so this is all about the Kamlesh presentation. Chaitanya has nicely shown about the various etiologies and the management of the vasospasm. He's mentioned about the role of verapamil in the intra-arterial use of verapamil. So, as a as an endovascular surgeon, we often use nimodipine as well as a milrinone rather than the verapamil, because verapamil has a very high chance of hypotension and the bradycardia during the. And as he has mentioned clearly, like one has to wait while using these medications, because immediately after installation of the medication, we may not see the change in the diameter of the vessel, but one has to always do. And the second thing, one has to repeatedly do the procedure. In fact, in one of our patient, we almost did this chemical angioplasty for almost a period of weeks time. So one has to keep this thing in mind, and because when we are doing endovascular procedure immediately after surgical procedures, one has to also make a balance about the use of a heparin during this procedure. Otherwise, sometimes patient develop an intracerebral hematoma. Avishkar has shown a very nice case, and we have discussed about this thing. What I feel like, Shushankar, during the first coagulation, maybe the vessel was, I am, because it was not shown in the video, but it was just the just over your forceps was just over the vessel, and then the tip was just very close to the fundus. And second thing, when you open the aneurysm and you inserted that your dissector, immediately gush of blood came. So as Dr. Mishra pointed out, maybe some thrombus or the blockage of the vessel. And we all know about handling of these small vessels in the parapulsate region are very prone for a change in the diameter. So that may be the reason like why patient develop spasm. So that is all from my side. Thank you very much.
Thank you. Thank you. Thank you very much. Sorry, Nitin, I know you've been waiting for a while. So you want to come in? You're still
Nitin.
muted.
Dr. Nitin?
You are
Can
muted.
you hear me?
Yeah, you're
sorry. So excellent talks by all the speakers and very well, presentations by all the speakers, I feel. The thing what I want to add was in the third case, which was a unique case, definitely well selected case for discussion because even Professor Mishra and all are not able to explain how this is possible. And I have also not experienced any time. But definitely one thing what I can propose or I can just think of is when there is a probability of when you are taking or dissecting the fundus or neck, if there is a bleed which is going to occur from the posterior aspect, which is not seen, as a protective mechanism, many a times the distal vessels may go into spasm, which happens and which is a known pathophysiology when there is an immediate rupture. So that is one thing. Of course, it is added by while we are dissecting, the sensitivity and the autonomic response is more. Plus, what is more important there is applying temporary clip for the small vessels. I would usually not do that. Okay, because that's always a dangerous proposition for us. Even if it is rupture, you can take a control there, and I usually don't apply temporary clips and avoid, especially in DACA aneurysms. So that is what I could add to the earlier beautiful comments given by Professor Mishra, Batuk, and you all both excellent moderators.
Thank you.
Thank you very much, Nitin. Before I come back to speakers, just have a couple of points to make. I have stopped using adenosine for a long time now. I won't use it for last 15, 20 years. We used to use it for first 5, 10 years. I just don't find it necessary. And believe me or not, I have hardly found the need to coagulate the aneurysm. I don't know. The aim of the surgery is to clip the neck. Why do we have to coagulate the dome of the aneurysm? I find it, at least I now find it, I don't find it necessary usually. Our radiologist will not do any intervention after vasospasm, even if patient is deteriorating, for two reasons. That's the reason they give now. I don't have a proof. They will not use intraoperative any nimodipine or papaverine or any other vasodilators because they say that the effects are short lasting, the vasospasms recurs, and there is no evidence that the long-term outcomes change. That's what they say. And they would not use balloon angioplasty because they think sometimes the risk of rupture and other associated complications because of balloon could be really detrimental to the patient. So as Dr. Mishra said, we also don't use Triple H therapy anymore. We make sure that the patient's electrolytes are normal and the patient is not hypotensive or hypovolemic, but we will not push their blood vessel and certainly not overload them with fluids anyway, mostly in elderly population. So yeah, I agree. So Dr. Shiva, you want to say something about you taking notes?
Yes, there are three comments and questions in the chat box. Two are to Dr. Chaitanya. They have also got his experience with intraarterial milrinone, and other question is about open about cleanup for the management of vasospasm. Dr. Chaitanya.
Yes, sir. So personally, I prefer nimodipine. I usually don't use other drugs. I have not used milrinone yet. So I usually use nimodipine and Clina, that as it was mentioned that you need to do it repeatedly. It is short lasting. Chemical angioplasty is short lasting. You may need to do it repeatedly. So we used to do it by placing a catheter, draping it with Tegaderm and taking all the preventive measures and continuous infusion for 24 hours. But that is more cumbersome. It's better to take it out, the catheter. There are complications also. So better to take it out, go in again if required, than this continuous infusion.
Okay, and Dr. Nitin and Dr. Gotuk, I think both they are hybrid neurosurgeons. Can you comment on the use of the same thing, like milrinone and Clenon vasospasms?
The thing is, continuous infusion like we were doing past in intravenous urokinase. It is not possible for an intra-arterial continuous infusion because we know about them. All the three drugs, nimodipine, milrinone, and verapamil continuous infusion, because we cannot give more than 1 milligram at a time in a one vessel, like at the most 4 milligram total dose. So it is practically impossible to keep a catheter inside the artery, and so rather than better, it's to you do the procedure maybe the twice a day, maybe infuse over a period of time, maybe for a few minutes, like over a period of over 20 to 30 minutes. Observe the patient because you have to have a continuous monitor of the blood pressure. If the blood pressure falls, then you have to immediately stop. So I have used a nimodipine, intraarterial nimodipine and milrinone, as I have mentioned above. I have not used a intra-operative verapamil, as well as I have not done a chemical, this thing, balloon angioplasty for vasospasm.
Okay, thank you, sir. Thank you. There's one question for Dr. Kamlesh, or any senior panelist and mentors can guide us about any experience with rapid ventricular pacing in intraop rupture.
I don't have any experience with adenosine or rapid ventricular pacing for that matter. I have not, I didn't have any opportunity to use both. Till now, we are able to manage our intra rupture without both these procedures. The seniors may like to comment if they have experience.
Actually,
yeah.
Sorry, I have not heard of rapid intraventricular pacing as a method to stop bleeding when there's an intraoperative rupture. I don't know as well. So perhaps anyone, Dr. Mishra might.
Yeah. Rapid ventricular pacing is a thing for elective surgery. Patient has to be completely evaluated. So it cannot be done for emergency subarachnoid aneurysm surgery. But there is reports in the literature, and you need full evaluation, cardiac evaluation. The cardiologist has to be in the theater. It's a simple thing. It's not a very difficult problem. And one of a very close friend of mine from Germany has a very large experience published and very good results. It's good for giant and complex aneurysms. It's not really kind of so necessary because it's a second, tier treatment. And he has very good experience. Volker Seifert has had a good experience, and I haven't used it.
Another thing I would like to say about Kamlesh, your case, that when you're doing entry communicating artery surgery, I think, it's very easy to criticize in retrospect, but you wouldn't want to do anything to the aneurysm unless you got both A1s in your hand. And if you're going to put temporary clips on A2s, I would rather put temporary clips on both A1s first and then put temporary clips on A2s. Because what happens is, you have one flow from contralateral A1 coming in, but there is no outflow allowed because both the A2s have temporary clip. So even if the aneurysm that is probably not going to rupture will end up rupturing.
Yeah,
But
that I mentioned, sir. Sometimes we get so carried away. Although,
absolutely.
yeah, sometimes we get the asymmetrical circulation. One A1 is dominant, other is non-dominant, yeah, hypoplastic. But in this case was both A1 was co-dominant circulation. So that I also mentioned. Sometimes we have to get carried away, and
That's true.
they just I can bail out, but sometimes we have to bite the dust and learn from.
That can happen very easily. Yes, that's true.
Okay, there's
Sorry,
one
any
more
other
question.
comment? Yes.
Anybody can take it. Is by Dr. Satish Krishnan. Is there any advantage of using intra-arterial video Doppler like one used by the cardiologist in vasospasm? So not heard about it. Sir, anyone can take up this?
I think so. There is there are two things we are using. One is the Doppler flow and
Yes.
Doppler velocity.
Yes, sir.
So, this fatty Cerebral group, they have this real flow. They give it the numbers, which is the standard of care in very expensive tool, which is available. I don't know whether what you have, Shiv Shankar, but what we are seeing the velocity only, right?
Translate.
So I think Satish probably is asking about that. That is definitely, if you have the flow, especially for bypass, that's a very useful tool. If you're doing a lot of bypasses and STMC small vessel bypass, that's a very useful tool.
Okay, thank you, sir. Never heard about it.
Can I ask a question to Chaitanya that I saw in one of the slides, it was shown that one of the steps you take to reduce intraoperative spasm is head shaking.
Yeah,
You
that's it.
and I just wanted to make sure that did I read it correctly? I
Yeah,
need
yeah,
my
yeah.
glasses.
So that was from Yeoman's textbook, and even I was surprised. So I guess these are all some the last measures, like maybe subarachnoid clots made. I don't know, but there was this thing like head shaking. Then they talk about exercise also. I guess that is all because in elective and good patients, I guess, like patients who have been discharged on postoperative day 2, 3, and then afterwards to prevent vasospasm, one may do.
Let's
I just have one comment. It doesn't matter where it is written. If some rubbish is written, you don't have to follow it. I mean,
Yes.
you talk of a patient who has got aneurysmal subarachnoid hemorrhage, you want to ask him to do exercise. I mean, that's ridiculous. But everything on the print, that is what it is important to realize, that everything on print and just because it written, it can be it is a gospel. So I think you have to be common sense has to be applied.
Yeah.
Makes sense. Yes, sir.
The other one more comment, Sipsankar, I would
Yes.
just, if there are any young neuroscientists, I don't know who are listening. There are many ways of doing the same thing. You heard Dr. Chaudhary talking that he has never used, never found it useful, which I said I use it always. So pick up whatever suitable for you. There's mostly because medicine, unfortunately, is not a true science, or it's not 2+2. There are so many gray areas in there, and there evidence to many things. We don't have class 1 evidence. So if it works for you, use it. These are some of the adjuncts which are available. Some of the things we found useful, others don't find.
Thank you, sir.
Another thing I find that people, when I see people demonstrating their videos, I find that many a times the intraoperative rupture that happens is because of excessive or unnecessary manipulation of the aneurysm. The aim of the surgery is just to clip the neck and preserve the parent vessel. And many a times, rest of the dissection is not necessary. And we have followed it now on for number of years, and I don't put temporary clip anymore. I don't find the need to. And also I have minimized the dissection to such a level that you find the parent vessel, find the bifurcation, find the neck, and just have enough space at the neck to insert your clip. And with experience, if you achieve that, I think the intraoperative rupture rate diminishes significantly. That's what we found, and I insist that my fellows do that as well.
Okay, well taken, sir. I think we are at the end of this discussion. And as Professor Bikimishra sir told, the intraop rupture and vasospasm itself, if we discuss, it goes for hours together. And our three speakers, Dr. Kamlesh, Dr. Chaitanya, and Dr. Avishkar, could conclude the whole presentation in right time. And we had a good discussion, brainstorming discussion by the senior mentors and panelists. As we know, for the last 2 decades, endovascular treatment has completely changed the way vascular neurosurgery was being practiced. So mainly these two complications of intraop rupture and vasospasm, they deter many of the young neurosurgeons to take up for clipping, and they easily shift for endovascular. And as in the present era, we feel that clipping aneurysm is a dying art nowadays. but I believe it remains as a refined and essential discipline to learn many of the techniques of dissection and even how to handle the complications like rupture and spasm. So the spasm is a common complication both in endovascular and even post-surgical clipping. So this art of clipping should continue, and I hope the webinar did the justice to the topic what we covered. And I thank all the speakers and panelists. Thank you for the wonderful presentation and discussion.
Thank you, Dr. Siva.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Thank you. Good night.
Thank you. Thank you. All the best. Bye-bye.
Thank you, sir. Good night.
Thank you, sir.
Okay, bye, guys.
Bye, sir. Thank you, sir.
Good night. Thank you.
Thank you. Good night.
Bye-bye.